My name is Peter Selby. I'm the Chief of the Addictions Division and a clinician scientist and physician here at CAMH. Healthcare professionals face many barriers identifying and treating people with addictive disorders. The first one is that this hasn't been part of anybody's education in any meaningful way, although at least 1 in 10 people will be suffering from some sort of addictive disorder sometime in their life. And those addictions affect why they're coming to a healthcare provider in the first place. So for example, the person who's having difficulty with, say, gastritis may actually be having a problem with alcohol, or somebody who is coming with weight loss and other problems such as that may be using a stimulant like cocaine, or the patient who has chronic obstructive pulmonary disease is actually heavily addicted to cigarettes. So addictions are all around us, but it doesn't figure prominently in the curriculum. One that has always stuck with me has been one of my patients who I treated for his polysubstance use. And we were able to help him stop using, and I was able to help him, the team and I were able to help him stop using his heroin. He switched on to methadone. He did really well on methadone, but he started using cocaine. And once we started talking about what that was about, he said very clearly to me that, look, when I was using heroin, it would numb me out. The methadone doesn't numb me out the way heroin does, but cocaine certainly helps me cope with those demons that I'm dealing with in my life. And so we spent some time exploring these demons, and it became very apparent to me that this man had been traumatized as a child. He had depression for pretty much most of his life that had never been diagnosed and treated. And so what we decided to do was to get him the appropriate consultation, the appropriate therapy. In the combination of medications plus his therapy, he was able then to become a functioning member of society, because now he didn't need to use that cocaine, which was all he knew of how to deal with his mood and his feelings. And so that really taught me that when we look at people with substance use disorders, we need to pay attention to the underlying or concurrent mood disorders or other psychiatric disorders that might be there. In my role as Chief of Addictions at CAMH, it is my role to make sure that every client coming into CAMH essentially is screened for both their psychiatric or other mental illnesses and their addictions and their use of substances, making no distinction between the two, but really making sure that all clinicians here, when they see any client, understand what is interfering with that person's level of functioning, how much of it are mental health symptoms, how much of it are addiction systems, and how are they interacting with each other. To put it in a nutshell, that is what I want to see happen here. And so that's the approach I promote with all my physicians, all my other people who work with me, and myself as well. When I'm seeing a client, I'm doing a full history and a full examination of not just their use of substances, but the other mental illness symptoms, as well as the other social determinants of health that impact either negatively or are impacted by mental illness, such as poverty, housing, education, work, etc. When I was a resident, I got so frustrated when I was treating this one patient who comes to mind who had sickle cell disease, and he had painful conditions. But when he showed up for one appointment, my supervisor, preceptor, would say, he's an addict, don't give him anything. And when he came back for his next appointment, the next preceptor would say, oh, he's in pain, give him all the medications he needs. And so I was getting confused. I didn't have a path of how to make sense of this complexity when the person had potentially both a pain condition and an addiction. One of the first things I make sure every learner understands is that mental illness and addictions are not moral weaknesses. There are clear biological and psychological features, including genetic features, that will make somebody vulnerable to an addiction or make it that much harder for that person to get better, including things like the environment in which they find themselves. So I ask learners to keep an open mind and to start understanding the addiction from several different dimensions so that they know that the person who is presenting to them is suffering from a brain being hijacked by drugs, and that what they are doing is nothing personal against them as providers. So if they seek to understand, they seek to help them, then they need to know how to motivate, and to learn that skill in motivating is critical, because what you're trying to do is to tap into what is healthy with that person while things are seeming chaotic, to engage them in care, and then once that engagement has occurred, then recovery is possible.